Started when you are ready.
All right, thanks so much. And we'll take a look when we do the roll call and see who else has joined. Hi, everybody. Good afternoon. Welcome to our February Plan, Design, and Expenditure Committee meeting. A special thanks to Helen Belanca, our chair of the board, who helped to facilitate the meeting in my absence last month. Katie, if you want to go ahead and get into roll call, and then I'm happy to jump into the agenda review.
Yes, definitely. Starting with Chair Diaz.
I am here.
Helen Belanca. Chun-Wei Chi. Dr. Rosemary Hemmings. Tony Germain.
Good afternoon, everybody present.
Thank you. Betsy Boyd Flynn.
Hello, I'm here.
Brian Frank. Eve Gray.
Present.
Gabriel Andine.
That's me.
Jim McGee.
I'm here.
Thank you, Jim. Jamie Osborne.
Here.
Thank you. Julianne Horner. Max Kaiser.
Here.
Thank you, Max. Peter Addy.
Yes, here.
Thank you. Peter Merritt.
Present.
Rob Fassett. Tosh Raman.
Present.
Thank you. And then I just saw Chun-Wei Chi.
Present.
Wonderful. And then I've got Rob that just joined. Okay, so that's everyone that we have so far, but I know a few people have reached out and said they're joining. So I will turn it back over to you, Debbie.
Thank you, Katie. Did they give you, would it be worth giving another minute before I get into agenda review, or did it seem like it might be a little longer?
Actually, yes, 1 more minute would be perfect.
All right, sounds good. So we'll go ahead and give that just a sec. And I apologize in advance for any barking in the background. Those are my fur babies, just trying to alert me to humans outside. Rob, is your hand up intentionally?
I was just in the process of giving him capability to connect his audio and camera, so it might have been related to that.
Perfect. Thanks, Katie.
Okay, I think that you can now go ahead and get started, Debbie.
All right, so we will go ahead and go to the agenda review. So we have already done our quick introductions and roll call. Next, we will have staff review the feedback from our last meeting. After that, I'm going to go through a sample straw proposal. It was posted in the materials. If you didn't take a close look at it, please don't fret. This is meant to be a sample and really to show kind of what a straw proposal will look like before it goes to the board for review. And I just want to take a minute to go through that, and in the hopes that by the end of this meeting, we may have a proposal, if not several, to consider putting forward to the board. After that, Danielle Ross with OHA will be going through our eligibility and enrollment overview. Following that, we'll have our small group report outs. Thank you so much to Cheryl, Eve, and Peter, who took on the behavioral health, as well as Tosh and Rob, who took on long-term care. So we will be hearing some of the report outs and the work that they've done in the interim from the last meeting. And then we will be breaking out into small groups. It's going to be a bit different this time in the sense that there's going to be 3 concurrent small groups with a longer, just shy of an hour amount of time for discussion. So you all, as we go through these presentations, can start thinking about which of the small groups you feel most aligned with wanting to discuss. The first one is going to be on the eligibility. The second will be discussing long-term care. And then the third, behavioral health. So this will be following the report outs and presentations and getting a bit more of a discussion in a smaller group before coming back out after the break and getting into our report outs from those. So you don't need to decide right this moment, but just know that that is coming. And there will be a representative from either our staff or consultants, as well as, will be assigned to different ones. So you just don't feel any pressure about which you have to decide now. I will also prompt you all. Hopefully, I'll remember to prompt you all at that time. If you need to take a quick bio break, that would be a good time, even though it's not built into the agenda, and then just join the discussion at your ability. So that's a nice kind of longer period of time where you can relieve yourselves as needed. Following those small group discussions, there will be a formal 10-minute break. And then when we return from breaks, will be the report out of those small groups. After that, we can have some discussion as time allows as well as a larger group. And then Helen Belanca will be reviewing, some straw proposal ideas in addition to the sample that you will see. And then we'll have some discussion about that and potentially consider a vote for putting forth a straw proposal to the board. After that, we'll roll into some more discussion, just reflections, feedback. If there's time or discussion that kind of carries over from the straw proposal ideas, we can allow that to flow. And then we do have, I believe, one member of the public who will be giving oral testimony, and then one written that was that I will review during our allotted time for public comment. And then we will be adjourning at 4 p.m. or whatever time close to that, leading up to that we naturally reach an end. And that is it for me on my part. So I will go ahead and turn it back over to you, Katie, or to whomever's going to be reviewing the feedback.
I will take that on. Hi, everyone. I'm Jenny Donovan. I am committee staff and staff for the Universal Health Plan Governance Board. I haven't joined you before, but I am the current interim executive director, and so I'm taking over for Morgan with her support of the committee. And so I will go over the feedback from the previous meeting, just to remind everyone of sort of the ideas that everybody came to consensus on and how we got to the meeting materials we're going to look at today. So basically, from last meeting, there was a review of the benefits plan and conversation about the benefits plan and general consensus that the task force recommendations for PEB Plus would be taken up, and the idea that no cost sharing and including vision and dental were something that the committee was interested in. Enhanced benefits for those who qualify based on income, asset, age, or disability for non-emergent medical transportation, health-related social needs, long-term services and supports, and early periodic screening diagnostic treatment. And so to continue that commitment not to reduce benefits was important to the group. General committee consensus for coverage limitations based on current PEB limitations instead of an elimination of certain benefits. And then finally, small groups will be looking at potential enhancements for long-term services and supports and behavioral health services. And you'll see presentations on from both of those small groups today before you go into your breakout groups. And so that's a review of what happened at the last meeting and sort of the general consensus that came out of that meeting.
Thank you, Jenny. All right, so now we're going to review a straw proposal example that kind of reflects some of those sentiments that Jenny just went over. There is a sample in your meeting materials. If we can get that pulled up as well on the larger screen, that might be helpful as well. And let me know if that's not feasible.
It is feasible and I'll work on that right now. It's just, I'm having a little bit of a delay.
Sounds good. Thanks, Katie. And then I'll just take a moment to say that this is not necessarily the straw proposal we have to go with. I just think it's helpful that we can take a look at what we previously reviewed, but filled out with a potential proposal. Perfect. Thank you, Katie. So this is just an example. We're not going to be voting or necessarily discussing deeply at this time. There will be room later on in the meeting for a more discussion on it. So as you can see, there's our committee that we're a part of. These are just dates pulled out, but ultimately a date that we submit, a date that the board will review will be included, and the topic of what the proposal will be covering, followed by a high-level summary. As you can see, this is a lot of words. Please don't feel the need to read this now, but this is something you can have and reflect back on. But this kind of just goes over the structure that was initially talked about with basic and enhanced benefits. And we also want to make sure that we are thinking about administrative as well as consumer perspective. Following that high-level overview is going to be a more focused proposal. And we'll see when we get to the end. I'm not going to, don't worry, Katie, about trying to rush there and risk even getting a little nauseous with the scrolling. But in our work stream, we'll highlight that document one more time, but this is basically just reflecting the work stream that we are a part of and how it aligns with the proposal. There will need to be someone, a champion of the proposal, which is a member of the committee. It does not need to be a member of the board who is on the committee. And this doesn't necessarily need to be the same person for every proposal that we submit. This can change, but that individual will address the board and address questions to the best of their ability. It's possible that you may not have all the questions that, or all the answers to the questions, and that's okay. Okay to say you don't know, okay to either have those of us present chime in if we have some input, and also totally okay for it to come back to the committee for some more clarification. This is really going to be kind of an iterative process. So after that, just talking a little bit more about our preliminary structure. This is, again, another document that you all have already seen, but it will be at the bottom again to reflect back on. I think it helps just to repeatedly see things and see them in how that we're going to be using them. But this is basically just citing the recommendations based on the board's preliminary structure that was agreed upon. We also have the values and principles document that will be at the end and is cited. And as always, we want to think about how this is aligning and tying back to our values and principles. And so calling them out specifically. And then this next one about the deliverables, again, references the workstream document that is below and talks about what deliverable that this committee is charged with and how this fits into it. And then at this part, it's finally is just talking about what committees other than ours are going to be impacted by this recommendation? What do we need from other committees? What kind of recommendations are we considering? And you'll see that finance and revenue, operations, and then in community engagement and communications were all called out and discussing. So for instance, in this plan, finance and revenue, we certainly, I think we've all discussed that quite a bit, how we need revenue estimates to really understand and truly understand what is feasible. And then based off this, there was no real need of operations at this time. And then community engagement. Think of these committees as kind of like a two-way conversation. Same thing with the board. We're communicating to them, they're communicating to us. What needs do we have? What needs do they have? And how does that fit into the proposal? And then, oh, I was wrong. Lastly, resources needed rather. And so this is just, we constantly should be thinking about what is it that we need to really consider the work that we're doing. And we're going to have some targeted discussion about this at a future meeting. But this is definitely something that as you think to yourselves, what resources are we needing in order to do the work that this committee is charged with doing? Please raise them to us as they come to your mind or send them in an email, but we will be asking directly at future meetings as well. And then the very bottom is just once it goes to the board, there's one of two options. Either it's going to be approved outright or what I consider to be the more likely, it's probably going to be brought back to us for revision and tweaking, and then submitted again. So again, this is kind of two-way communication. It's not what we come up with in a straw proposal is just that, a straw proposal. It is not final. And then here's that phase 2 work streams that we were talking about, and ours is work stream number 4. Here, oh, it's okay, Katie. Here's the preliminary structure that was decided upon. You can kind of refresh this as you need to. And then again, our values and principles document. So if you have a minute, to go back at a future time and look at this example and kind of how it ties back in, staff will be helping us to actually put it into this format. So our discussion later will be just that, a discussion, and not so much filling in this paperwork. And I think that is all I have to say on that. So I will kick it back to you.
And then we just have a question from Helen.
Oh, sorry, Helen, I missed your hand. Yes.
That's okay. Thanks, Debbie. That was great. And I just wanted to give a little bit of context for folks. I know that Debbie went over this at, I think, our first meeting, but as she mentioned at the beginning here, the purpose here is for us to ideally come up with some sort of straw proposal that we want to present to the board. And this process is in place because we're trying to, this is our communication strategy between the board as a whole and all of our committees. We don't want the committees to get so far down a rabbit hole on one plan of how they want things to go without sort of checking in with the board that it's the right direction. And so the idea here is if we get to a sense today of where we want to go with one or more of these issues with eligibility and then the benefits discussion that we've been having the past few meetings, then the idea is we submit a straw proposal to the board and we say, we think this is the direction the plan should go. Are you good with that? Is that kind of, does it align with what the board wants us to do? And then as Debbie just said, the board can give feedback on that. And then that will kind of give us the go ahead to kind of dive deeper into it and work it out. So in a straw proposal that we propose today, the whole idea is we don't have to have all the details worked out. It's just like conceptually, is this the direction we want things to go? And we get the nod from the board, and then we can work with staff to go deeper on those. And then ultimately, a final proposal from this committee will go to the board to be incorporated into the overall plan. But it's just a little bit of a feedback and stepwise process.
Thank you, Helen. I appreciate that. All right, and then next we will have Danielle Ross with OHA, our policy analyst, go ahead and give us the overview of eligibility and enrollment. Feel free to take it away when ready.
Awesome, thank you. Hi, folks. I'm Danielle. I'm a policy analyst with OHA, but I've also been a student and a volunteer. I've worked for private employers in Oregon. I have family and loved ones and other lived experience here. But today I'm presenting on eligibility. I'll keep it to 20 minutes, so I might talk pretty fast, but we'll have time in the breakout group to discuss some of the stuff that I cover today. So let's get started. This presentation will cover our committee's charge and where eligibility falls in our work stream. I'll discuss the questions that we've collected from the committee and the chair as a starting point, and I'll include references to which we can look for guidance on these topics. So our committee's charge, I wanted to note that the discussion questions that appear throughout this presentation are just to get you started on thinking about the recommendations that you'd like to consider. And at the end, I've summarized them all in a slide that I'll share in a breakout group when we get talking about eligibility. Next slide. I wanted to recenter this presentation in the context of the Plan Design Committee's charge. So eligibility recommendations are part of one of our deliverables in our work stream. It's the second part of a 4-part deliverable that includes benefits, which we've already talked about. There's eligibility, and next you'll be moving on to provider reimbursements and cost containment strategies. Next slide. And to organize this presentation, I made sure to consider our eligibility directives in our enabling legislation, which is Senate Bill 1089, and also our board-approved preliminary structure. So Senate Bill 1089 directs us to secure healthcare for all residents. So that's where we're starting with eligibility based on the bill. And our preliminary structure, again, specifies all people who live in Oregon will qualify. and they also specifically direct us to consider non-residents who work in Oregon. The preliminary structure, as far as eligibility, also mentions that the plan will work with providers that are licensed or authorized to practice in Oregon. Next slide. So let's get started on your questions. DCBS and OHA staff collected the questions that we've heard from the committee so far. Those generally relate to defining residency in Oregon, Medicaid eligibility examples and some comparisons. There's coverage while traveling. We heard questions about out-of-state providers and out-of-state dependents. Also a slew of questions on non-resident workers who commute to work in Oregon and migrant workers who live here seasonally, so several months out of the year. We also heard questions on how the plan will treat temporary visitors. And lastly, questions on how incarcerated individuals will be covered under the plan. Next slide. And before we get started, I want to note these questions are very complicated. They're very nuanced, but lots of different public and private bodies in our state and other states at the federal level and in other countries have had these conversations before. So we have lots of models to look at. We're scratching the surface here, but like your values and your direction will kind of shape what models we look at in the future. So let's start broadly with defining residency in Oregon. This is the size of this population is 4.2 million people per the US Census Bureau, and they define residence as the place where a person lives and sleeps most of the time. So I looked at 4 residency requirement models that are currently operating in Oregon. I started with Medicaid, OHP. It's the least restrictive. It doesn't require documentation of an Oregon address. It only requires attestation that Oregon is home. I also looked at public school districts, which require documentation, voter registration, which requires documentation, and then the DMV, which is the most restrictive. Either you must present documentation of an Oregon address, or if you're staying with family or you're unhoused, for example, there's a 6-month waiting period to establish residency before you can get a driver license. Next slide. Continuing our discussion of Oregon residents, I wanted to offer some context on people who move into and out of the state each year. So these are 2022 numbers. About 128,000 people moved to Oregon that year, and about 158,000 people left Oregon that year. Again, this fluctuates. This is just a point in time. But I wanted to note that the median incomes of these folks that are coming and going are comparable to our state median income of about $38,000 in 2022. And the task force recommended, the recommendation that's relevant to this population is that we allow individuals to enroll in the plan at the point of care. So it's a no wrong door policy. So folks who are moving to Oregon, according to the task force, would be able to enroll when they seek care for the first time at a provider's office. This may fall under the work of the operations committee, so I don't have a specific question for you guys right now. Next slide. So on to the question about OHP eligibility. OHP includes a residency requirement and an income restriction. Again, of the models in Oregon right now, OHP's is the least restrictive residency requirement. And as far as the income restriction, if we use OHP requirements to determine eligibility for enhanced benefits, which you guys have talked about in your benefit discussions, enhanced benefits are like long-term services and supports or health-related social needs. If we use OHP's model, then income would likely be a consideration, but OHP also requires specific social and clinical circumstances for these benefits. A couple of questions for the committee to consider. Should the Universal Health Plan use OHP's residency requirement model? And should the plan use OHP's requirements to determine eligibility for enhanced benefits? Next slide. Okay, on to the question about coverage for Oregon residents who are traveling. To define this population, we're talking about individuals who are residents of Oregon and are temporarily traveling out of state. So it's impossible for us to get a solid number on how many people travel out of Oregon each year. I also wanted to note that this includes residents who work in a different state, and the Oregon Employment Department estimated that number at about 66,400 people in 2021. And I am not sure if I'm answering questions throughout, but Betsy, if I could ask you to maybe write it down and come discuss it in the breakout group, that would be fantastic. Thank you so much. We have limited time. Okay. So the task force on this population recommended that the plan cover Oregonians who travel just as commercial plans cover out-of-state travel right now. And so that means if we look at commercial plans, they only cover emergencies. That's one of the ACA's 10 essential health benefits. But you can choose other plans that may offer lower reimbursement rates if you seek non-emergent care out of the state. Or if you get a more expensive plan, these commercial plans might offer coverage for out-of-state provider networks, again, with higher cost sharing for most plans. Some questions for the committee to consider in our breakout group. Do you want this universal health plan to cover emergency services for residents while they're traveling? And do you want this plan to cover any non-emergency services for Oregon residents while they're traveling? Again, we will have models to look at depending on the direction you want to go. Next slide. Okay. So the next question is pretty closely related to the last one. How will we cover out-of-state providers? And to define this population, we're talking about providers who deliver services to Oregonians, either while they're traveling or Oregonians who live here, but live near the border and other providers are closer than providers who are in Oregon. The task force recommended, again, that we cover Oregonians who travel just like commercial plans currently. But I wanted to note that in the task force's work, their public engagement focus groups elevated out-of-state providers as a priority for rural Oregonians. So often in rural counties, it's easier and closer for individuals to visit providers who live outside of the state or offer services outside of the state. And I wanted to keep those folks in mind while we're talking about out-of-state providers. So looking at existing policies in Oregon, again, commercial plans vary in their coverage, but I wanted to look at OHP to get some idea of the numbers and the size of this population. For OHP, out-of-state providers can register with OHA to receive fee-for-service reimbursement. There are special circumstances. Sometimes it has to be a service not offered by providers that are near our OHP enrollee, and it typically requires prior authorization. But our number of enrolled out-of-state providers to provide OHP services right now is about 16,000 providers, and that's to serve a population of about 1.4 million people. So just wanted to offer some context. And then the question for the committee is, will the plan allow out-of-state providers to enroll with a universal health plan? Again, it's not a black and white question, but we can look at models depending on where you want to go. Next slide. Okay. Again, closely related question on out-of-state dependence. To define this population, we're talking about individuals aged 26 and younger whose parents are residents of Oregon. So these individuals may have permanent addresses in Oregon, like college students who are studying in other states, or they may have a permanent address in another state, and we don't know the numbers or the size of this population right now. The task force recommended, again, that we only cover Oregon residents. And as far as those who are traveling, we cover them similar to current commercial plans, kind of vague. So I wanted to look at some existing policies in Oregon to give us some more context to consider. OHP, like all state Medicaid plans, does not cover out-of-state dependents with permanent addresses in Oregon. So if you're living in Oregon and you're traveling and you're a dependent who is out of state studying, a college student, for example, your coverage is only for emergencies. As for out-of-state dependents who have permanent addresses in other states, you don't get any coverage at all. You're not allowed to be on your parents' Medicaid plan if you're a permanent resident of a different state. You have to apply for Medicaid in your new state. I also took a look at PEB plans because we're using that as a benefit model right now. And you have a couple of different options as a PEB employee or as a PEB enrollee. So you can choose a plan that does cover out-of-state dependents with addresses in other states if the parent's plan covers provider networks in those other states. If you don't choose a plan that covers provider networks in other states, then your out-of-state dependents are not covered except for emergencies. And so your kids up to age 26 would only get emergency coverage. So the question that I want the committee to consider when we get to breakout groups, do you want the universal health plan to extend coverage to residents out of state dependents? Next slide. All right, so let's move on to non-resident workers. This is, again, a population that the board's preliminary structure specifically directs us to consider. And to define this population, we're talking about folks who don't meet any sort of residency requirement in Oregon. So this includes remote workers who work for Oregon employers, commuting workers who come here physically to work on a daily basis, and migrant workers who work here part of the year but don't live here the whole year. So these folks earn wages here, they file income taxes in Oregon, but none of them permanently reside here. We have some estimates on the size of this population from the Oregon Employment Department. They approximated the number of remote and commuting workers at about 120,000 individuals, which is a large, in my opinion, a significant number of our wage earners and income tax filers here. That's about 7% of people. And about 80% of those folks are people who commute from Vancouver, just for context. And the number of migrant workers estimated by the Oregon Health Authority and their dependents who live here on an annual basis, but just for part of the year, is about 174,000 individuals. So the task force, their technical advisory group, considered this question, but the ultimate recommendation was to only cover Oregon residents and omit those non-resident workers. So this went against the technical advisory group's recommendation, which included covering residents in neighbor states who commute to work in Oregon or work remotely within a commutable distance. Debbie, you had asked what they define commutable distance as. It didn't make it to the final task force report, but one of the TAG members, Michael Collins, chose the number of 75 miles. But there are other definitions for commutable distance. I think you had mentioned 60 miles, but the task force TAG was looking about 75 miles. And the legislation, Senate Bill 770, also asked the task force to consider this population. So omitting this population went against their legislation. The reason it was omitted was due to projected cost. So if you look at the task force's final report, the Optimus expenditure modeling in Appendix B, when the task force saw those numbers, they just decided to omit the non-resident worker population. And so questions for this committee to consider are, will the plan extend coverage to non-resident workers? And if so, will eligibility requirements consider Oregon state income tax filings? The reason that I included the income tax question is because, depending on our financing structure, these folks would contribute to the plan via taxes. Again, these are nuanced questions, but just getting you guys thinking about them right now. On to the next slide. So to the question of temporary visitors, this population, we're talking about individuals who visit Oregon, but don't live here and don't earn income or file taxes here. So this includes students, and I don't have good numbers on the size of that population, and tourists. As for students, our public universities, U of O and Oregon State University, have a non-resident student population of around 47 to 50%. So it is a significant number of people, and students often purchase student health insurance plans from their universities. And to the size of the tourist population in Oregon, again, hard to nail down. We don't know how many people drive into and out of Oregon every year, but Travel Oregon reports that in 2022, we recorded 29.7 million overnight stays and $13.9 billion in travel spending. So this is a pretty significant part of our economy. As for the task force recommendations, again, only Oregon residents. They did not address this population specifically. They did have a note that for people who are visiting Oregon, the plan should seek reimbursement for services received by temporary residents and visitors for injuries or acute illness. So if folks are visiting, the plan will seek reimbursement from their insurers. If they're visiting here and not insured, that is something we have to consider. The task force also specifically recommended that subsequent bodies, which is our board and our committee, work to more fully define visitor coverage and to ensure some level of visitor contribution to the plan. They specifically called out a sales tax, but I wanted to note that hospitality taxes and gas taxes can also be contributions to the plan, in addition to beer, wine, and marijuana taxes, people who come to visit wine country, for example. So while the task force only mentioned a sales tax, that's not the only way to get these folks to contribute to the plan. I wanted the committee to think about, do you want this plan to extend emergency or non-emergency coverage options to temporary visitors, including non-resident students? There's a couple different definitions we could use for emergency, but this is just to get that conversation started. Next slide. So the committee members have specifically called out incarcerated individuals a couple of times. To define this population, we are talking about approximately 12,000 adults in custody and about 500 youth in custody in state institutions. We have one federal prison, Sheridan Federal Prison, which has right now about 1,500 adults in federal custody. The task force didn't make any specific recommendation on incarcerated people, just stated that more work is needed. So I went to look for existing policies in Oregon. One second. So right now, the State Department of Corrections Health Services Division delivers healthcare to incarcerated individuals. That division received a general fund appropriation of $418 million for the last biennium. So that's just over $200 million a year for a population of about 12,500 people. And that's all general fund. We don't receive any federal funds for our Department of Corrections. For our one federal prison, the Federal Bureau of Prisons receives appropriations and delivers care for people incarcerated in that institution. There are questions about federal funds being used in carceral settings. Right now, we can't use Medicaid money there. And folks who are veterans, for example, can't get any VA benefits while they're incarcerated. And that's with our 1115 waiver notwithstanding. You might know that we're soon going to offer benefits to folks in their last 90 days of incarceration. But generally, federal funds can't be used in carceral settings. So a question for the committee to consider is, will the Universal Health Plan provide care to incarcerated individuals instead of the State Department of Corrections? Depending on your answer here, we can look at a couple different models in other countries and see how to move forward on this topic. Next slide. This is one that the committee did not specifically ask about, which is federally recognized tribes. I want to be clear that I'm not qualified to represent a tribal perspective. I don't want to give that impression, but they're specifically called out in our legislation, in task force recommendations, and in our board's preliminary structure. So there are 9 federally recognized tribes in Oregon, and the enrolled population is over 24,000 individuals, according to the Oregon Land Justice Project. That is distinct from the number of individuals who identify as American Indian and Alaska Native, which is a larger population. This is just the folks currently enrolled in the tribes. The task force recommended that tribal members have the choice to enroll. They specified that we'll have a government-to-government relationship with the tribes, and there will be no changes to tribal health systems. Our enabling legislation, Senate Bill 1089, only specified that the board will evaluate how to work with the tribes, and our board's preliminary structure specifically said members of the tribes, including providers, will have the option to participate in the plan. Next slide. So I'm at time, just over 20 minutes now. We have some other considerations around federal eligibility and the one enrollment system in Oregon. These questions likely fall under the operations committee. And I'll look to the chair. Debbie, do you want me to go through? I think this is slide 15. I've got a few more slides, or we can just stop here and move into talk about this stuff in breakout groups.
I think it's appropriate to stop here and go over this at breakout groups, if you think that's appropriate as well.
Yes. Katie, will you go to the second to last slide, please? Just back one. So this is the matrix I'll show you guys in the breakout group. It just has a brief breakdown of the topics I talked about today, so that when we have discussions, we have something to go off of. And thank you so much for your time. I really appreciate it.
Thank you so much, Danielle. I appreciate all the information. That was a big order. Definitely appreciate it. And those of you who are interested and have questions and want to discuss this more in depth, that'll be appropriate for the small group. All right, so we are going to move forward to our small group reports, starting with behavioral health. So I will turn it over to Cheryl, Eve, and Peter, however you have decided to share that.
Peter, do you want me to kick it off? I don't think Cheryl could make it today.
Yeah, go ahead. Thank you.
Okay. So there was, I think not in this PowerPoint presentation, but in the materials handout on the current coverage by different types of providers for behavioral health services. And essentially, today, Medicaid has better coverage for a higher variety of providers to include qualified mental health associates, peer support specialists, as well as now moving back to a requirement to work in a qualified setting. Unlicensed mental health professionals are also covered by Medicaid, and not very many commercial plans. Some of them are, but not all. Then there is a list of services covered by insurance type. Essentially, all types of insurances are covering inpatient behavioral health, outpatient behavioral health, residential alcohol and drug and mental health services. And then we start to drop down with which insurances will cover things like housing supports or other community-based mental health services. So think about the increased use of mobile crisis, stabilization centers, and then other sorts of day treatments, community-based treatments, which are largely Medicaid funded and also have some backing from the state general fund. So I think our initial thought was that, and certainly from the task force, we don't want anybody, or and the board, we don't want anybody losing coverage. So we, I think, are recommending the broader suite of coverage of both provider types and services that are available in Medicaid for behavioral health services. And there were some things, bullet points on this slide that we just wanted to call out. Specifically, there are some kind of loopholes. So case management with a qualified mental health associate or a peer is covered, but only in face-to-face services. And most case management actually happens without someone in front of you because of the hours of work to coordinate. So we felt like that was something that would be valuable to include as an option for coverage in a new plan. I mentioned peers and case management covered by Medicaid and not other insurance, but there's also, even with Medicaid, a requirement that a full assessment take place prior to being able to bill for any type of outreach and engagement services. This is a barrier because of the lack of qualified mental health professionals that we have, and folks end up spending a significant amount of time without treatment, waiting for their assessment to take place. Team-based, evidence-based programs across the lifespan. So ESA and ACT are currently covered under Medicaid. So if we were to go with the pathway of focus on Medicaid eligible services, those should be covered at least in part. Those are also subsidized by the state general fund currently in our state. You can see intensive in-home behavioral health treatment, capacity based services like 24/7 crisis stabilization. That's an emerging model, treating people who are in behavioral health crisis, not in an emergency department or the jail, which is often where folks end up being treated, but instead coming to a stabilization center with behavioral health providers that are uniquely equipped and desire to treat people who are having a behavioral health emergency. So that is something that we would encourage. Mobile crisis services also, these are covered by Medicaid today, not other payers. And we felt that it was important to cover behavioral health services regardless of location of care. So there are mobile and street-based codes that can be utilized now. For physical health care, we feel that it's important to have those for behavioral health care as well, particularly with folks who just have trouble getting into a clinic or making an appointment. Making sure we have good group, family, and couples coverage. That can be sticky and depending on the insurance plan in terms of whose name do you bill under and how do you manage the reimbursement for those services. Talked a little bit about ketamine assisted therapy, and we encourage that we check to see whether that's covered under PEB. I don't think it is today covered under Medicaid. But there is some interest in emerging evidence in this area, and would certainly be interested in a review of the evidence and identifying what we could look at for coverage there. We also felt that if there is a body that is reviewing research and making a determination about what's covered based on evidence, we wanted to make sure that there was behavioral health expertise on that body and not primarily or being overly heavy toward a physical health focus, because that's some of the way that we think maybe our behavioral health services have not been covered in the same way on other insurance plans as physical health services, and has resulted in the lack of parity. We also had a lot of discussion on reimbursement. That's going to come later on, but I included the sub-bullet points here. Acuity-based reimbursement for in-person treatment, assuring therapists are reimbursed similar to other master's trained clinicians, so physician associates and nurse practitioners, and potentially looking at, and this may not be BH specific, but would we want to incentivize providers who are providing evening and weekend hours, which we all know that we have difficulty accessing off hours care, and feel that some incentives might be warranted there. So Peter, what do you want to add?
I think that's a really good overview. Thank you. So yeah, we're just looking at different ways to expand coverage, let's go, of both the kinds of services we're looking at, as well as the kinds of providers that we're looking at. So those are the, other than that, I think you covered it very well. Thank you.
I see Helen has her hand up.
Thanks. This is really great. Even Peter, can you just clarify, like, I heard you say that, OHP coverage for behavioral health is a lot better than some commercial plans. Of this list, is everything on here? I don't think everything on here is covered by OHP. Like you mentioned, ketamine assisted therapy is not. Is there a way to say, like, to separate it out and say, here are the things that OHP covers that commercial plans tend not to, and we want to make sure that those are included, so that we call those out. We know we cover those already in OHP, and we just need to, put that over in our plan. And then here are some additional things that aren't covered by OHP, but we think should be, and those need to be explored and sort of developed, because currently sort of nobody's paying for them. Does that make sense?
Yep, we can work to split that out.
And just eyeballing it, is there a lot in that second group, or is it mostly just the ketamine?
It is the first two bullet points.
The case management and peer there's no coverage for peer navigation and case management?
Not prior to a full assessment.
Oh, I see.
You can't do outreach and engagement before a qualified mental health professional has evaluated the patient.
Okay. Yeah, it would be great to separate out, like, here are the things that are currently OHP covers, and we just got to make sure to include those. Yeah. And then the other things that we would love to see. That would be great.
You can see kind of a version towards that answer if you look at it's not in the slides up here, but if you look at the download, I think we're in section 5.1. There are some graphs. There's a nice graph on page 2, payer reimbursement by service. that goes into some detail. We could still do more detail, but that's a start.
Great, thanks.
Thank you both. Jim, I think you were next.
Yeah, you have this one bullet point here that says, assure we have, make sure I'm off mute. Okay. Assure we have good group, family, and couples coverage and mechanisms for billing that. I'm not sure I understand either what it means or the relevance.
Yeah, Peter, do you want to speak to that one?
Yeah, currently we see differences in so as a couple, as an example, if each partner has different insurance or different locations in and out of state. If we're looking at, I know a number of people, I've tried running groups a few times as an independent practitioner in outpatient, and it's just not really financially feasible unless I have 10 or 12 people in a group. So that's more of a reimbursement question than an eligibility question. I personally don't know anything about family therapy, but I've just heard from other providers over the years that that trying to get coverage for couples and families can be kind of tricky when we're dealing with multiple systems.
So this
But
is
if we're
in
going to
ref-
have a
this is in
universal
reference-
system.
This
Oh,
is in
yeah.
reference to group, family, and couples therapy sessions,
Yeah.
and not thinking into, I was thinking of it in the context of commercial group plans having, family coverage, single coverage, couples,
Okay.
and not quite getting the rep. But thank you very much.
I
That's
see.
very helpful.
All right. And I do want to be mindful of the time. Just we will have a small group to discuss this. So Jamie, I'm happy to have you do your question unless you intend on being part of that small group, in which case I'd ask if it can hold till then. All right, thanks so much. And then I want to make sure we have time to get into long-term care. Tosh and Rob, I will turn it over to you two as you choose.
All right. Can you hear me okay?
Loud and clear.
Awesome. Okay, so I'm gonna start my timer. All right. Thank you, everyone. So we did our work on long-term care, and we will start off the presentation with what is long-term care. It's healthcare and related services for people who have functional or cognitive limitations. So we looked at functional limitations, which is activities of daily living, such as eating, bathing, and dressing. And you have the instrumental activities of daily living, such as paying bills and preparing meals. So these limitations can vary based on age. Younger people tend to have more intellectual or developmental disability versus like the older people, they have Alzheimer's or other kind of dementia. Next slide, please.
Yeah, so we wanted to include some information about what the costs that are typical of long-term care are, just to establish what the stakes are for Oregon families. Medicaid will start to pay for long-term care when you're eligible. Typically, that is an income or assets determination, as well as as Danielle was referring to. They're beyond just qualifying for Medicaid. To qualify for long-term care benefits, there are social and clinical considerations that go into qualifying. But for the most part, qualifying for Medicaid means that you are poor. And so typically what long-term care in many states looks like is, you pay out of your own assets until you're poor, and then Medicare kicks in. These costs are generally borne first by the people who need care and then by their families. And then when families can't pay, they're often taking on the burden of providing the care themselves, missing work, dropping out of the workforce, and other sort of carry-on effects like this. So in equity terms, those are costs that are, all the costs that you're seeing here. Some of them are monetary, the ones that are posted here, but other ones you can sort of are social. Those are borne disproportionately by women, obviously primarily an issue for working class and working poor, and then therefore like a disproportionate racial impact as well. Next slide. So this is just some information about what long-term care insurance actually costs, and you'll see at the bottom, at this point, only about 3 to 4% of Americans age 50 and older pay to have a long-term care insurance policy, which makes sense if you kind of look at the last column, annual premium of such a, average annual premium of such a policy for a couple. Most people don't have that kind of money just lying around to pay for something that they may or may not at some point later need. So this reflects the annual, the premium dollars here to some extent reflect the annual cost of LTC services, but only for a particular population, that population that will buy long-term care insurance, which is only 3 to 4%. Doesn't really reflect what it would actually cost per person to cover everyone with some kind of long-term care benefit, because there's a selection of who's getting it and who's not. The Affordable Care Act, one of the things that it did, and I would never argue that it solved all our problems, but one of the things that it did is it had a mandate for people to, and I'll just wait on Jim's question till the end.
One thing to keep in mind in the private insurance.
Sorry, I'll just wait on your question till the end.
Oh, I'm sorry.
Oh,
sorry.
no worries.
Sorry.
So, one thing that it did is it mandated that people get the coverage, which, again, for better or worse, made it so that average per person cost was lower. So that's something that as we'll talk about later, some countries and other systems have done to kind of bring down that per person cost, is to actually mandate that people are involved in some sort of long-term care program or insurance or something. Next slide. As an industry, the long-term care insurance industry has lost a lot of money. There are different reasons for that. Don't want to spend too much time on it, but long-term care as a product is very hard to price because of the long-term nature, because you don't know who that population is that you're covering. At a whole population level, some of those questions become easier to answer. There's some other information on the slide. For time, let's just move on. So a lot of the rest is reporting on what other places do. There's this domestic other places, and then Tosh will take over with some international other places. But one other place that does something for coverage, universal coverage for long-term care, is the state of Washington. The program was passed in legislation back in 22 or 23. Benefits start in 2026. They have some kind of lead up period to when, where they're funding it and taxing for it, and then till when it kicks in. And what it is, you get vested in the program by being a resident and paying taxes in the state for however many years, and then you get some fixed benefit to pay for long-term care for you, as an individual. And starting in 2026, that benefit is $36,500, which doesn't sound like a lot relative to those numbers on one of the previous slides, and that's true. But I would just say that $36,500 can pay everything for some people, and can at least give people, some time to plan. Like, suddenly we have a long-term care need. What are we going to do? The question is either, you start paying out of pocket right away, or you have a little bit of a buffer where you can kind of take some time and plan and think about how to pay for that. And I like, that model is something that you can kind of start small and then expand sort of as your capacity builds to the point where you have something like full universal coverage. And then, so that's Washington, and some other states have explored just expanding Medicaid eligibility, eliminating asset tests, just expanding the population of Medicaid. There are some federal guidelines on, on who qualifies, but states do have a lot of leverage and flexibility that I think Oregon could use more of. Next slide.
All right, so over here, what I tried to look at was other countries, how they fund their long-term care services. But I wanted to focus on 3 key questions: how it is funded, whether it's sustainable or not, and how do the majority of recipients receive care. Next slide, please. So we looked at Australia. Australia was particularly interesting to me because right now their system has a basic model and a supplemental model. By virtue of being an Australian, most Australians get access to a basic set of services. And then people who have more money or their income is at a higher level, they can buy supplemental insurance. So in Australia, government acts as the primary funder and regulator of aged care. Funding is insufficient, which is why they're exploring the prospect of long-term care insurance, private insurance. 1.5 million Australians benefit from care, with overwhelming majority receiving care at home in 2022. One of the ways they keep their costs lower. Next slide, please. Canada is a little bit more like us. The primary funding comes from government with additional contributions coming from private insurance, but you'll see a significant portion of out-of-pocket spending. Most of the care is publicly funded or subsidized. Residents do have to contribute a lot more towards their accommodation, but based on sliding scale, they may not have to pay anything. Most of their services is provided in institutional settings. And next slide, please. Germany was a little bit more, as from my research, seems like Germany is doing a lot better in long-term care than other countries. They have a mandatory long-term care insurance in place, and it's financed by both government and public and private sector. Their private insurance is age-based, not gender-based, and I wanted to make this point because when we did our research, we looked at the insurance premiums go up for females versus males. So Germany doesn't do that kind of they don't allow for that kind of discrimination. We also what I also saw was that there are a lot more the services are a lot more in nursing homes versus like traditional getting services at their own homes. But they do have some kind of transparency. They have a public report card, which is available for people to compare different nursing homes. And that kind of is their way to have some kind of compliance and quality metrics in place. Next slide, please. Japan has one of the oldest population in the world right now. And you see a lot of their long-term care universal service is provided by the government itself through premiums that are collected from citizens 40 and over. A bigger co-payment burden, but most of their services are fee-for-service, kind of like what we have for Medicare. But they do have an incentive for nursing homes to get additional payments if they perform better. Next slide, please. Netherlands has a universal private insurance sector. So everyone has to, kind of like what Washington is doing, they have a private health insurance that's compulsory for everyone to participate in. They also have a lot more system in place to make sure people do enroll in those programs. Sometimes they will send them fines, and after a certain time, if the people still don't enroll, then they'll just automatically enroll them. They have means tested deductible, and it kind of shaves off some of the burden that more vulnerable people have, and a significant of the portion of people who receive those services, they receive it in long-term care facilities. Next slide, please. Sweden has a tax-funded model, and financing is kind of shared between different layers of the government. Most people receive services at home. And next slide, please. So this is what we came to. Our recommendation for this committee is to create a committee, and I should have put committee instead of saying subcommittee. I want it to be a different committee that has more experts in the long-term care field, but they can explore the possibility of instating a universal long-term care insurance that is funded by taxes with a future go-live date, or they can instate a model that emphasizes cost containment strategies like prioritization of home services, like we have showed in several slides that home services do cost less than your typical nursing homes. Option 2 would be to explore the possibility of expanding the eligibility for Medicaid, something that Rob discussed. It will cover more people, but not all. And the third option would be to regulate the industry some more, so that long-term care insurance, when they go out of business or their premium prices skyrocket, it protects the Oregonians from the effect of that. And I think that's about the presentation we have. Thank you for listening.
And then can we circle back really quickly? Jim, did you want to share your question with Rob and Tosh?
Well, actually, it wasn't so much as a question as a comment. I just want to make sure that people appreciated that the long-term care and insurance industry are notorious medical underwriters. And so those premium costs reflect the cost for healthy people and not necessarily, any indicator of an average cost.
Peter?
I was wondering, when you're looking at the foreign models, if there's any reliable data from China, Cuba, Vietnam. I think those would be, the first ones that come to my mind when I think of universal healthcare.
I have not looked at those countries. Kind of the papers that I came across focus primarily on those 6 countries that I mentioned in my presentation.
But I would just say that Cuba obviously invests a lot in the medical field in a way that they actually produce a lot more doctors, physicians, and generally speaking, a more robust system than we have. So I think I agree that those are worth looking into, but yeah, there are going to be some other very large systemic differences that will make a full translation somewhat more difficult, for sure.
All right, and then we'll go Tony.
Well, first off, just a great deal of gratitude. This is tremendous presentations today. I really appreciate Mrs. Ross' presentation and that of behavioral health and this last presentation. So thank you all for your contributions on that. I did want to touch on that last with the 3 options, and I'm just kind of curious as we get into thinking through these discussions. Was option 3 targeted to the status quo, but then ensuring protections for that? So essentially would be maintaining the integrity of what people would receive based off of their income and assets with regard to long-term services. Is that what option 3 is kind of referring to?
Yeah, I would say that's right.
Okay.
And I would say that speaking for myself, the options are in a definite order of preference from a sort of ethical position.
Great, no, that's helpful. Thank you.
Thank you, Tosh. Thank you, Rob. Katie, I'm going to turn it to you to orchestrate the divvying up of the small groups.
Thank you, Chair Diaz. So the next portion of the agenda is committee members are going to be able to choose which group they would like to be in. And there will be one group for eligibility, one group for long-term care, and one group for behavioral health. And like Debbie mentioned before, each of those little small workout groups will have a facilitator and that will kind of lead you all through it. But one thing to keep in mind in those groups is please just make sure before you wrap up that you determine who will be sharing your readout. Because then what will happen is after the small groups are done, we're going to go right to break. And then we'll come back from break, and that will be where we do the readouts from each group. So with that being said, what we'll do now is I'm going to open up 3 breakout rooms. And then you are going to be able to, in Zoom, down at the bottom ribbon, you'll be able to kind of play around with that to figure out how to click breakout rooms and join the one you want to add. So we'll get going with that. But Tony, did you have a comment or a question?
Just curious a process. So the intention is to go in and kind of discuss these three different sectors, kind of explore the content of decision making, but obviously, are we intending these breakout groups to come back with a recommendation or more just a space to talk through things?
I'll jump in. A recommendation would be ideal, but I think it ultimately depends on where the discussion goes. And even if that recommendation is potentially having a work group, for instance, eligibility comes to mind. There's a lot of nuance there. If a work group would be needed in the interim between next meeting, but if you can come to a recommendation, that would be ideal. And we'll talk a bit as a larger group as well.
Great, thanks.
Chair Diaz, how do you feel about doing small groups until 3:05, and then we'll go right to break at 3:05?
That sounds great. And just a reminder, if anybody needs a bio break now that we're a little over an hour in, please feel free to, I will be taking one before joining the discussion. So relieve yourselves as needed.
Okay, I'm going to go ahead and open up the rooms. And you should be able to choose which one you would like to
if you scroll all the way down, you'll be able to join the room.
And Jamie, if you would like me to assign you to a room, I can also do that as well. For everyone returning from the breakout rooms, just a reminder, we're going to go right into break and we will reconvene at 3:15. All right, it's now 3:15, so if we could just have committee members re-engage, and then Chair Diaz, you can take it away when you are ready.
Thank you, Katie. Katie, do we have everyone back or most back?
Yeah, I think people will continue to kind of get reconnected over the next minute or two, but I think you can go ahead and get started.
Okay, if we get to you and your report out individuals not here, we can just go to the next group, but we can start with the report out for eligibility if we have all members or at least our reporter available.
I can vouch for the reporter since I am he.
Excellent, Jim, take it away.
First, let me preface by inviting any committee members to correct me where I err. The first question we tackled was one of defining residency, and I would say that we probably leaned toward the Oregon Health Plan model. There were some who argued for the public school district model, but I think there was consideration that, number one, fraud is probably not likely in this scenario, and that the plan ought to err on the side of being more generous rather than less generous. There was also a question raised about getting some models in terms of what other countries do. Coverage while traveling. I would say that this was the area where we had the widest spread of opinions. There was a strong sentiment that we only cover emergency services when people are traveling out of state. But there was an argument made, I think, by me for sure, that the plan covers people and not services or location, and also raised the question about how do we think about retirees who retired with an expectation of healthcare and have moved to the Sun Belt, and what's their entitlement to healthcare in the future? There was some talk about thinking of those people in terms of a transition period. Out-of-state providers, I think, was probably the most agreement, I'm going to guess. I think where the group seemed to land was recognizing that the Oregon Health Plan allows people to be sent out of state when recommended by in-state providers, and that a lot of border area providers are treated as in-state providers. On the question of non-resident workers, I would say we probably had more questions than answers. One of the questions was, how does an employer now provide for his or her non-resident workers, especially if those non-resident workers might be virtual workers on the East Coast. And then there was a lot of discussion, not all of which I followed, but you know, the role of taxes. Do these people pay taxes? Does that entitle them to a benefit? How many people are we talking about? What is the cost of these? And then towards the end of the discussion, the question was raised about people being allowed to opt in or out of coverage. I don't know if I missed anything, but and then the last two topics we talked on very briefly, so I can't say for sure that there was agreement, but the opinion that was raised was that we should cover incarcerated individuals for reasons of both administrative simplicity and care continuity. And also that we wouldn't want this plan to provide less than the Oregon Health Plan. And then on the issue of temporary visitors, there were two viewpoints expressed because we just plain ran out of time. One was to agree with the task force, and the other was to recognize that students who attend universities in Oregon are required to have, or normally required to have, coverage and that it would not be a huge leap to roll them into this plan. So does anybody in my group want to, I shouldn't even call it my group, this group, want to add to or subtract from what I offered?
I think you did great. Thank you.
Are there any questions? Oh, Jamie.
I may have missed it, but I didn't hear about your recommendation to cover Oregon residents out-of-state dependents.
Well, we didn't differentiate between Oregon state dependents and non-dependents, shall we say.
Brian?
If
Whoops.
the scenario that I'm thinking of is somebody in a hospital in eastern rural Oregon getting flown to the nearest hospital, which happens to be in Boise. And I guess I'm just not clear from what all's been discussed, if that's considered emergency and we would cover it, or if that's considered an outside provider and we would not unless they were in the border. Because I think that's the sort of thing that will sink families.
So I think, as I understood the discussion, number one, certain border providers could well be considered as in-state providers. And secondly, if the provider is recommended by an in-state provider, say a physician says the best place you're going to get coverage is Boise, then that would be covered as well.
Thank you.
Rob?
Yeah, just wanted to comment on a couple of things because I regret missing the discussion. But one thing was the opting in or out for people out of state. Anytime you're offering an opt-in or out, it's very tricky selection questions that I think I
think the opt-in and out pertain to people who might by virtue of employment be employed outside of Oregon, but still be paying taxes in Oregon.
Whatever the class is, I would just personally be very careful offering an opt-in or out. And then on the case of students, yeah, they are required to have coverage generally speaking, but they're also usually buying that coverage either from the school or through some other way. And so if we have like out of state students coming in, obviously it does make sense to cover them, but like if there were a way to maintain that revenue stream, like the revenue they would otherwise be paying for their insurance, like going into instead the health plan, that's something to consider on the revenue side.
Makes sense to me.
Maybe Jim, just one thing that we came up with a scenario. Let's say somebody lives in New York but does remote work in Oregon and pays their employer.
Oh yes, that's another
that
good
way.
idea.
Is one challenge that we were kind of discussing surrounding that is that individual largely wouldn't be able to obtain services for healthcare delivery in Oregon because they're geographically so far away. So thinking about that geographic boundary and thinking around the Idaho border and Vancouver, thinking, as OHP does with contracting with some of those services just geographically that way. One idea we kind of were discussing is, could that be, how many of those I think is an important question, which we need to kind of investigate to look at. So that was one thing we were interested in seeing. But one idea kind of considering was, could that be almost like a credit that could be applied to a plan that they could get, they get services in that state, should they be on the other side of the country?
Eve, I think your hand was up next.
Thank you. I have had commercial insurance in the past where my insurer was part of a network, a national network of health insurance companies, so that if I was traveling, I was able to use the preferred provider list in any state I was traveling in that was part of the national network. to me, that would be ideal to have, you know, you may not cover every provider out of state, but to have some in-network providers for folks. Otherwise, if something goes wrong while you're traveling, you end up in the ER, and that's a bummer because a lot of times what you really need is a lower level of care, but you can't wait to get home. That also is having some sort of a network plan like that would also address the needs of remote workers who are in different states, because there would be some in-network providers who would be covered by the plan. I don't know what the, I've not worked in health insurance. I have worked in many other parts of the healthcare field, but not health insurance. So I don't know what that takes to get to be part of one of those national networks, but maybe something to look at.
Thank you, Eve. Helen, I saw your hand and then I saw it go down.
I was just going to ask the group if they felt that there was enough consensus on the majority of these issues, that they just want the staff to kind of summarize the recommendations and bring it back as a straw proposal, or if you feel like a subset of you or all of you wanted to continue to talk about it and work out some of these issues. It sounded like you were pretty much in agreement, but I might be misinterpreting that.
Well, given that we were kind of rushing through each of the topics, you know, I wouldn't say we've adequately captured everything, but I think fairly close.
If the staff were to kind of draft a straw proposal around eligibility and bring it back for the next meeting to kind of look at, would that be sufficient, or do you want to do some more work in between now and the next meeting?
Seems to me that'd be like I mean, I'm just speaking for myself now. A good next step.
Which one? I gave you two options.
Drafting a proposal.
Drafting a proposal. Okay.
Yeah.
Okay.
Saves me the problem of trying to make sense out of these notes.
I think we had general agreement, a few questions around that, but I think it would be productive to start with that. And I think the staff were taking a lot of notes, so not assumed, but I think that would be a good start.
All right. Thanks, everybody. Let's go ahead and move on to long-term care.
Yeah, so I'll try to be quick. But one of the main things that our conversation say moved toward was something like option one, trying to do option one as well as possible, recognizing the need for more expert input on the question and probably needing to get to that anyway at some point. But the idea of trying to come up with something like a Washington model that can be layered into the existing long-term care system, which is largely based on Medicaid, to cover those people who don't qualify for Medicaid. So, sorry about this. And so that could look like not including long-term care as such in the Universal Health Plan itself, but having it carved out to the Department of Human Services, where they would operationalize, they would administer like all of the long-term care out of there in a way that, you know, is able to differentiate between, you know, people that qualify for Medicaid, people that don't, what the benefit option is. Because again, summarizing that Washington version, it's like a lump sum amount where, you know, you sort of have to be vested in the program for X number of years paying taxes. We did a little of research during our meeting that in fact it really is only for workers paying a payroll tax. If you're, you know, the spouse of a worker, you're not paying in, you're not earning that benefit. So that, like, because of the extensive, you know, cost that long-term care can bring, there is a real possibility of selection for people to, you know, move once they have a need, if the only requirement is basic residence, which is then also like something that we really want for the universal health plan. The universal health plan itself, what we really want is residents to be the only determining factor. And that with long-term care, you know, what Washington has done suggests that they decided that's sort of not feasible, even in their limited scope model, with the political will that exists now. And so that like carving that out of the universal health plan, but exploring additional like legislation to develop some Washington-like model that involves some sort of vesting, even if not, vested by paying income tax or payroll tax for X number of years, but at least say by being a resident for X number of years, or some sort of vestiture model based on residence, might make sense. Anything I left out that people find important?
And I guess I'm not getting any hands from everyone. Is this feel like a place to have a straw proposal? Was there consensus within your group of that direction, or something that could be written up as such, or how were things left?
I think there was consensus around writing that up as a straw proposal, unless someone objects right now.
Okay.
But then also taking questions.
Tony?
Yeah, thank you guys for this is a tough conversation, this one. In essence, the straw proposal is to make recommendations that this be a separate process outside of the universal health care plan. Was there discussion about evaluating the cost of when we take it to an actuary and look at that to see what option 2 and then option 3 essentially is the existing structure for enhanced services based off of income eligibility, age, and assets, right? Just wondering if you guys discussed that in essence. So we would remove this from the plan, but it would be a parallel path. Is that my understanding of it? Okay.
Yeah, and we didn't discuss as far as having the actuaries price it, although by all means, as far as I'm concerned, like it is actually very difficult to find out on a per person per month basis what it costs. I think it would be difficult, or what it would cost to just fold in, say, a full long-term care benefit to the full universal health plan. I mean, there's suspicions that that will be an extremely large number that will make it extremely difficult to get the revenue needed to include it as like a benefit for all residents. I think that's going to be really difficult to put a number on at this time, given all of the things about our system.
The one, sorry, Rob, keep going.
That's fine. Go ahead.
Just point of clarity is that these are guaranteed benefits for those that are meeting that at this point. So it would have to be included in the actuary. So essentially 3 has to be included in our look, right? What we're making a distinction is that if we had full coverage for a plan, would be option 1. Am I correct?
Yeah, I don't think the actuaries would need to consider it at all if the waiver. So the state's going to be applying for a waiver to, fold in all the Medicaid funding, all of the Medicare funding into funding for the universal health plan instead. So if, for example, the long-term care piece of the Medicaid benefit is not one of the pieces that's being folded in to the universal health plan, it just wouldn't really be part of the waiver. It would still be funded through Medicaid kind of in its own way. And the actuaries that are analyzing the cost of the universal health plan, I don't think would have to consider it, because even for the people who qualify right now through Medicaid, it still wouldn't be part of the universal health plan costs as such.
That's true if we don't get the waiver. If we do get the waiver and we fold in Medicaid, then it would have to be included.
I'm going to
We'd
let Helen speak to that.
Yeah, we're going to get into this a little bit more in the next few slides when I talk about it. I am not an expert in this field at all, but and if anybody knows more on this than me, please jump in. But my understanding is that even right now, if you qualify for long-term care through Medicaid, through an income eligibility, that service is administered through Department of Human Services and not actually through Medicaid. I think that's right, but jump in, correct me if I'm wrong, if anybody knows different than that. And so kind of what the proposal would be is that we would continue to pay for long-term care for anybody who meets income eligibility for OHP. It just wouldn't be through the Universal Health Plan. And in the slides that are coming up after this small group discussion, I'll get into a little bit more detail about what that might look like. But yes, we're not taking away benefits from anyone. If you qualify based on income, you'd still get them. It would just be administered differently.
I am far from an expert either, and I'm over my skis on this, but yeah, I have more questions about it. And what you just articulated is the questions regarding that and who has ownership of that, and where is that delivered from, and where is that accounted for, that pot of money, right?
Right.
And so when we're doing our calculations, so appreciate that.
And just to say, there, for actuaries doing this work, there would be data to help determine what, supposing that that valuing it for the current population is part of their work. There is data available to do that. It's the historical experience data of the long-term care services that are typically provided in Oregon for people who qualify. You could analyze that and you could project it forward and get some number for what it will be in the future. When you expand it to everyone, that data, I think, becomes inappropriate to try to use for that projection. And there's a lot that could go sideways with trying to use that same data to project for the broader population. And especially when you consider the possibilities of people establishing residence for the purpose of using a specific benefit, which I don't think we want to think about too much. But in the case of long-term care, because it's such a huge liability for most people when it is needed, necessary to consider, and I just don't think there'd be available data to easily or reliably project that.
All right. I want to be mindful of the time and make sure that we can have our behavioral health report out. Eve, is it okay if we hold your question until the next item that is going to continue to touch on this a bit, or was it more of a comment? I guess if it's more of a discussion based, it might be best to table that for a little bit if that's okay.
I think my only request is that we look into programs for all-inclusive care of the elderly and those funding models and make sure that we don't disrupt that system as a result of what we're doing here.
Thank you, Eve. All right, and now going on to behavioral health, and we'll have Peter reporting out.
Yeah, thank you. How much time do you want? I mean, we're like over the limit already.
We're over the limit. I guess just succinct as possible and to the chase, and then that way we leave a little room for questions and brief discussion, and if we need to, we'll go from there. So maybe let's start with 5 minutes and see how that goes.
All right, yeah, let's see what we can do. So I think we all agreed that we want to use OHP as the blueprint. We don't want to have less than OHP currently offers. A lot of what OHP offers is there's various gatekeeping based on income or acuity or something like that. So we could look at tweaking, how people, like what is needed, what is required for a person to be eligible for a service. But as far as the actual services themselves, I want to start with whatever it is that OHP covers, with particular emphasis on community, going out into the world. So community alcohol and drug in particular, community mental health, peer delivered services, traditional health workers, very important, school-based services. So meeting people where they're at is very important and cost effective, as well as the people who are with very complex needs are often kind of a residential sort of program. So going out to school-based, residential, and crisis services, both. So this is phone crisis, mobile crisis, crisis facilities. Definitely need a lot of emphasis on crisis services because that can be preventative so that people don't need the other services. We talked about we request definitely a lot of the questions that come up here are about reimbursement. How do we incentivize providers to offer the stuff that we want to be covered? And so that's a conversation for a subcommittee or a work group for specifically for reimbursement around behavioral health. So that would be a good thing to have maybe between now and the next meeting, I guess. And that sounds like a good overview. What am I missing? Yeah, Eve, anyone else?
I think the only thing, this is Janine, was we did talk about integrated behavioral health, which is sort of part of that community-based emphasis that
Yeah,
was.
integrating behavioral health and primary care. Yeah, absolutely. My own aside on that, Cuba has this as a model. They call it the polyclinic. It's very successful over there, where you have primary care, behavioral health, what do you call perinatal, maternity care, like everything all under one roof, and very easy to do referrals that way and just kind of determine acuity like immediately on site. So that would be very helpful to encourage and cover.
Any questions, comments, additions?
I mean, I would just say what I said before, which it would be great to clarify for those of us not in the field, which of these are the OHP ones and which of them would be new things that aren't currently covered that you would want the universal health plan to cover.
I think the graph, I don't know if we can pull up the graph that had that light blue. That might be a nice visual. Tony.
Yeah, I really appreciate the kind of delineating the differences. And, this has evolved so quickly over the last decade. And I would say we want to think about where we want to go, not where we've been. And thinking of what is working well. And as a primary care doc, having integrated behavioral health with warm handoff method for the last 10 years, I'm not going back. We need to integrate that throughout primary care because it delivers good quality outcomes and the best we can. Now, payment methods for this have struggled for years, and we moved towards value-based capitation and have some of that now. But I would encourage us to look to see how we make that continue to be robust. And I do believe OHP is a good steward of that in trying to move us that way.
So this was a visual that we had up and we're using as part of our discussion. We can also, if we don't land on a proposal today, if folks are okay with maybe some email correspondence over the next week or so, as an option, just since we are getting short on time.
Yeah, I mean, I think probably, my understanding of where we landed for a straw proposal was everything that has the light blue would be included in the plan. And then I think there was also a plug for if we could provide some level of peer or case management services, maybe a limited number of visits prior to the assessment and diagnosis, that would help with our wait lists, with getting people access to something before they get in.
Thank you, Eve. Yeah, and I think the kind of just arbitrary number thrown out was something like 20 hours, was it? But yeah, just that was kind of where we ended our discussion. Do folks feel like that's an appropriate straw proposal to submit to the board, or would some email correspondence outside of this meeting be preferred?
I'll say straw proposal.
Okay. Any objections? All right, going once, going twice. All right, and we'll go ahead and turn it over to you, Helen. And we do not I will briefly speak to a written public comment that was received, but we do not have any oral public comment today. So we did buy back a little bit of time.
Okay. So what do you think, Debbie? Do I have like 5-8 minutes?
Let's see. Yeah, maybe I would say, yeah, 5-8 minutes, and then we'll see what as far as continuing a bit of the discussion from earlier.
Yeah. And I appreciate what Debbie said earlier. I don't want to pressure anybody. This is complex stuff, and it's a big group, and all of the input that I've heard today has been really interesting and valuable and worth thinking about and worth kind of digging into a little bit more. And so I don't want us to feel pressured to come up with straw proposals if we're not totally sure on it. And I think seeing things in writing always helps me. Like, and so if we feel pretty confident about some of these, regardless, I think we'll write things up, and then if folks are willing to check their email before the next meeting and just read through what we think we heard, and then comment on those, I think that'll help Chair Diaz and the rest of the staff kind of present that to the board. The board wants to kind of know what direction we're heading, and so we just want to get some ideas on paper of what we think, but we want to make sure that we heard things right. So, when we talked at our last meeting, so we're kind of straddling two topics. One topic is benefits and what benefits we're going to be offering, and then the next topic is eligibility. And we're kind of in between the two. And it's a little bit hard to sort of fully dig into eligibility until we feel like we've sort of wrapped up the benefits discussion. So that's why we were kind of hoping for a benefits straw proposal today. But like I said, if we're not there, that's okay. So what we had talked about last week as a possible straw proposal for benefits was that all Oregon residents would have a baseline set of benefits with PEB as a basis, in terms of utilization, and then additional behavioral health benefits, which we just heard from Eve. So everything in that blue, plus the proactive case management and navigation outreach. So it would include that we just all agreed on, and then full dental and vision for adults and kids. And then we had talked last time that we would have this enhanced benefit for residents who meet certain income and/or disability qualifications, which includes the non-emergency medical transportation, the ESPDT, the health-related social needs, and then the long-term services and supports, and that you would access those if you met the guidelines for them. Go ahead to the next slide. So since we discussed that, the work we've done in the interim and thinking that through is each of those benefits has different eligibility and income requirements. So for instance, you don't automatically qualify for the health-related social needs just because you're on OHP. It's sort of a subset of folks on OHP who meet other eligibility requirements. And so each of those bullet points of the enhanced benefit package would require sort of determining eligibility all over again. And so it actually turns out to be like 6 or 7 different plans instead of just 2, you know, the main one and the enhanced. It's like 6 or 7 in there, and it's a little bit complicated to say the least. But also the problem remains that the more we dig into long-term care, the more we realize that that system is deeply broken and insufficient. We have an aging population. We have people living a lot longer than they used to. We have less family support in general than we did several generations ago. And so the issue of long-term care and the cost of long-term care is a really pressing one for the healthcare system. And right now it's like you can pay for your own commercial long-term care insurance, which for people above 50, only 4% of people who are 50 years old and older have long-term care insurance. So that's obviously not a robust system. And then your other option, if you don't have that, is to spend down your assets until you qualify for Medicaid, which sounds horrifying to me. And I can't imagine what families must go through in order to get to that level. But that's kind of where we are. And that seems really insufficient. And as several people have pointed out before, our current long-term care insurance is based on a really select population of people who have the means and the wherewithal to get that insurance. And if everybody were getting long-term care, the population and the actuarial equation would look really different because it would be a whole different subset. So there's a number of concerns about long-term care that make it sort of a very complex issue for the Universal Health Plan. And I worry that this enhanced straw proposal that we were talking about leaves so many people out of the loop, and sort of creates this gap in care that is a problem. I think it was Tony who said we do need to do the actuarial analysis to see what it would take to cover everybody with long-term care. But we know from other states who have looked into this that it absolutely bankrupts any system that is trying to do it. And that's why there aren't really commercial plans that cover long-term care. Medicare doesn't cover long-term care. The only insurance system that covers long-term care is Medicaid, right? And they do it through a different series of fundings, but sort of everybody has done the calculation and said, we can't afford that. We can't afford to cover all of our members' long-term care. It's just absolutely tanks any system. So we will look at it, but it seems really unfeasible to say that the Universal Health Plan will cover long-term care for everybody. The kind of the writing's on the wall on that. Next proposal. Okay, so here's just a quick visual. I'm not going to spend a lot of time on this, but Medicaid pays for about 50% of all long-term care right now, and little tiny 5% is paid for private insurance. So even people that do have private insurance, it's really small. This number here says 2% of Americans. This is all adults. Only 2% of all adults have long-term care, but it's 4% of adults over 50. Next slide. And then here's some startling statistics that I'll let you all read on your own. About half of us are going to need long-term care, and it's super expensive. And in Oregon, it's like $11,000, $12,000 a month for long-term care, it's just wacky expensive. So even in-home care is just untenable for most families, and likewise for the state to cover for everybody. Next slide. Okay. So this is the straw proposal that I'm hoping this group is willing to consider. We talked about this a little bit in the long-term care subgroup. And so one idea for us to consider is, like I said, I think that currently long-term care, even in OHP, is administered by the Department of Human Services and kind of separate from Medicaid per se, OHP per se. And then we have these other programs that for like the K plan, I think the K plan for disability services, and then NEMT and health related social needs. And those are kind of administered a little bit separately. You qualify for them if you meet income guidelines, and they're considered part of OHP because we fund them through OHP waivers, but really they're kind of their own separate program. So one idea for an alternative proposal is we could say that under the Universal Health Plan, all Oregon residents have an identical set of benefits. We would use PEB as a basis, the additional health benefits that we just went over, full dental and vision, ESPDT, peer recovery mentors and doulas, like all those supports would be available to everybody, no matter what, no matter where you live, no matter how much you make, no matter what, that's the UHP. And then we pull out long-term supports and services and pay for them and run them separately. So this would mean like long-term care, like nursing home care or in-home care and services and supports would be paid sort of through a Washington model. Maybe we did a separate tax. You would still get it for free, you know, and if you qualify currently for OHP, it would just be administered separately. So if you meet income eligibility for OHP, you wouldn't have to pay any new tax or new revenue for it. You would still get it for free, but everybody else might have an income tax. As Rob was saying, payroll tax isn't a great idea like Washington's model, but we'd come up with some revenue source that everyone would kind of chip into, and it'd be sort of a public model so that every resident in the state had access to long-term care, again, with some sort of vestiture, maybe length of time living here. But if we just chunk that out, put it somewhere else and make sure everybody has access to it, that might be a really worthwhile thing to do, have it run by DHS, and then it's out of our math calculation for the cost of the universal health plan, and it's available to everybody. Similarly, the current supports and services that are in OHP now, so non-emergency medical transportation, health-related social needs, I'm missing some, but those two are the big ones. Those would still be available, and if you qualify for them, you still get them. CAPE plan for disability, you still, if you qualify, but again, they are currently sort of run by, right now it's like this complex interplay between DHS and the Oregon Health Plan. And so we could just carve those out and say, those are not part of the universal health plan. You still can get them. They're just going to be accessible through DHS. We could simplify how you apply for them, how you access them. And then they run all those separate eligibility requirements. All those different eligibilities for all those different programs would be run by DHS, and the universal health plan would be available to everyone. I like this idea because one of our goals on the board is to remove the inequity around the care that you get dependent on what card you show up with at the clinic or the hospital. And so depending on who's insuring you, you get different care. And we want to remove that inequity. We want everybody to say, you know, healthcare is a right, and healthcare, if you show up and you need healthcare, you should be able to access it. And it doesn't matter how much money you make, and it doesn't matter where you live. This is just a basic set of benefits that everybody gets. And doing it this way would sort of simplify things, so that we all had the exact same benefit. And then there's these additional things you can qualify for based on all these other eligibility requirements, but they are run separately. So that's kind of a quick overview that I was hoping we would consider. Again, we don't have time to have a robust discussion about this, which I was hoping for. But if people have thoughts on it or want to comment on it, or we can just send it to an email and you could give us your comments and feedback in writing and we could compile those.
I was wondering do you think this would be an appropriate quick explanation of like a fist to 5, just to kind of get a sense of where folks are at?
That's a great idea. Yeah, go ahead.
Yes, Eve, sorry.
Has ODHS been brought in on this recommendation of what they would be responsible for? And if not, I would love to hear their feedback prior to giving a fist to 5.
Absolutely. No, they have not. Nobody's even broached. This is just kind of brewing, but this is the idea of a straw proposal in the sense of like, do we like this possibility? Should we go down that rabbit hole? And if we do, then yes, that's our first step, is we got to get in contact with them and see what the feasibility of it is. But before we put the committee time and effort and staff resources into it, you know, if this is something that we think might be worthwhile, then yeah, we could pursue that, but we haven't yet.
For folks not familiar with the fist to 5, Kate or
Debbie,
Helen, did you? Yeah.
Yeah, I wonder if we should just say
table it.
Well, first decision is, do you want to vote on this now, or do you want to read more, think more about it, and sort of do it by email? And if people want to vote on it now, then we could do like a fist to 5. So like that first option would be, do you feel like you definitely want this as a straw proposal, or you're not sure and you need more information and want to table it? Those would be options.
So a thumbs up and a thumbs down. So thumbs up, straw proposal; thumbs down, table it.
Yeah, I don't think we have a thumbs down emoji,
but just in the, if everybody wants to put their actual hands on camera. Yeah. Old school
thumbs up. Yeah, thumbs up means you're ready to commit to this straw proposal. Thumbs down mean you're not sure yet, you want more information. Is somebody counting?
Katie, do you mind
It's
counting?
pretty-
I'm scrolling through. It looks kind of even to my eyes.
Yeah, it's honestly, I feel like there's too many thumbs down to.
Okay.
Okay,
Thank you.
good. Okay.
Thank you. All
Yeah.
right.
Let's think
That-
it through and write it up and.
All right. Thank you, everybody. Sorry that we ran out of time. I'm just going to briefly say we did receive a written public comment from a licensed acupuncturist in Northeast Portland, Ocala Wellness, and I encourage everybody to read through that, both committee members and members of the public. And that's all I'll say for now, since we are at time. I'm just ending with a quote. It's one of my favorite things about board meetings, honestly. And so this is a quote from Anne Frank, The Diary of a Young Girl, obviously the English translation. I don't think of all the misery, but of the beauty that still remains. I haven't abandoned all my ideals. I still believe, in spite of everything, that people are good at heart. Thank you all for your time. We will draft some of the straw proposals. Look out for your emails, and then we will be bringing more discussion to next time.
Thank you.
Thank you.
Thank you.